I'm
Yes,
going.
yes, smile is visible. The
Okay.
sound is.
So I'm going to start foot pathology today. And in foot pathologies, regarding the ultrasound examination, you have already seen Baxter's nerve as well as plantar fascia in the ankle class, I think. So it will be easier for you to go on from this anatomy, USC anatomy. Okay. So there are a list of diseases that I'll be going through today. You don't be surprised. The list is long, but I'm just going through the ultrasound examination in these diseases, so it won't take too much time. So but I'll be taking time, bit more time in disorders of plantar fascia and the neural compromise, especially the Baxter's neuropathy and other diseases. I'm just going to show you the ultrasound images and the diagnostic implication of it in our clinical practice. Okay. So starting with heel pad syndrome. Okay. So heel pad syndrome is much more common in pain clinic, especially patient with heel pad syndrome comes in athletic background. So it is mainly related to sports relative activity, as well as like in case of army officer, police officer. In these conditions, the heel pad syndromes are much more common. So causes of, if you go to the causes of heel pad syndrome, main is acute trauma. So mainly if the patient falls from the height and directly lands on the calcaneum or heel of the foot, then there can be chances of heel pad syndrome. Or it can be chronic conditions, such as in case of marathon runner or long distance runner. There can be chronic repetitive stress in the inferior aspect of the heel, and this can cause heel pad syndrome. So if you see the ultrasound image, I have included the normal heel of the patient as well as the pathological heel. So left side of the heel, where there are lots of arrows, are basically the pathological aspect, and the right side of the picture, which basically is the left heel of the patient, this is the normal. So you can just compare the difference. Okay. So in right heel or the left side of the picture, you can see the heel pad is enlarged and also there is a mixture of anechoic or anechoic and heterogeneous shadow just over the calcaneum. So this is the calcaneum. Just over the calcaneum, you can see there is anechoic and hyperechoic structures over it, and you can also appreciate the heel pad of this patient is thickened. But if you see the normal side or the other side of the heel, where there is no pain, you can see normal heel pad with no edema or no thickening of the heel pad. So this is a typical picture of the patient with heel pad syndrome. So in acute condition, you will be able to see edema or hematoma just below the calcaneum and within the subcutaneous fat of the heel pad. Okay, but in chronic condition, there can be either heel pad edema or heel pad atrophy. So heel pad atrophy is usually seen in very obese patient, or if the patient is more than 50, then we may be able to appreciate heel pad atrophy. But normally there will be heel pad edema even in chronic condition. So whenever patient comes with inferior aspect of heel pain, you always have to think of various differential diagnoses. So first thing in your mind should be plantar fasciitis, because it is one of the most common pathologies that is encountered in daily clinical practice. Okay, so heel pad syndrome is not that common, but plantar fasciitis is very much common in day-to-day clinical practice. Second is Baxter's neuropathy is also very much common. Third, foreign body in the foot is also common, because the patient we can, sometimes we walk barefoot, and various foreign body can find its way into the plantar aspect of the foot. And rarely, sometimes soft tissue tumors or rheumatoid nodules can be a cause of the inferior aspect of the foot pain. So coming to the most common clinical disorder in the foot, that is plantar fasciitis. Okay, so plantar fasciitis was very old name. Nowadays, people like it to be called as plantar fasciopathy, Mainly the reason is initially they thought that there was inflammation was the major event, but later on we all know that there is no inflammation, no active inflammation in plantar fasciitis. Basically, it is repetitive degenerative process which leads to inflammation and tendon disorganization. So nowadays we can call it as plantar fasciopathy, but we can call it both, okay? But nowadays people would love to call it plantar fasciopathy instead of plantar fasciitis. So if you see the anatomy, if you see the right side of the slide, you can see a beautiful this plantar fascia, thick plantar fascia running along the whole plantar aspect of the foot. So it is a very thick connective tissue which runs along the whole of the plantar aspect of the foot, and it basically maintains the arch of the foot. As you may have noticed, our foot is not flat, it is slightly arched. So this arch of the foot is maintained by plantar fascia along with some other ligaments. So other supportive ligaments are short and long plantar ligaments, which also supports in maintaining this arch. But main role of maintaining this arch of the foot is by plantar fascia. And it basically takes its origin from the calcaneum. So calcaneum has the medial and lateral tubercle. From the medial and lateral tubercle, this thick plantar fascia arises, and it extends and goes near to the level of the head of the metacarpal. And at the level of head of the metacarpal, it has a very complex insertion. So these are all insertion of the plantar fascia. And if you see the anatomy of plantar fascia, it has a three basically bundle. The main bundle is central bundle. As you can see, this is the central bundle, and it has a medial and lateral bundle as well. But most of the clinical condition in plantar fasciopathy basically arises in the central bundle. So and the problem in the lateral and medial bundle are very much less common. Okay, so what are the causes for the plantar fasciitis or fasciopathy? Main is overweight. Okay, so we know we are human beings. We basically stand on a foot, and our whole weight is dependent, basically dependent upon, is carried by the Achilles tendon, and then from Achilles tendon it goes to the ankle and then foot. So the plantar fascia has basically are on extreme pressure when we are standing. So this pressure will increase if you are overweight. So overweight is one of the main cause of plantar fasciitis. Another is elderly people and middle-aged people, because in middle-aged and elderly people, this plantar fascia is basically under degenerative process. So there can be plantar fasciitis, and it is very much common in middle-aged and elderly patient. Second, other conditions is diabetes. Similarly, systemic enthesopathy, especially the psoriatic arthropathy, ankylosing spondylitis, as well as in rheumatoid arthritis. In these conditions also, the plantar fasciitis are very much common. And chemotherapy-induced plantar fasciitis has also been reported. Various infections are also prone to lead plantar fasciitis, such as retroviral infection, gonococcal infection, tuberculosis. These are all infections that can cause plantar fasciitis. And foreign body in the plantar fascia can also cause plantar fasciitis due to repeated injury and inflammation. And plantar fibromatosis is also one of the cause that can cause plantar fasciitis. Okay, so these are the most common cause. In my clinical practice, I basically overweight, middle-aged, and elderly patient, and main is the inflammatory arthropathy in the patient with like rheumatic diseases, as well as in case of ankylosing spondylitis. These patients commonly, if you ask the history, then they will tell you that they used to have plantar fasciitis, or they are having active plantar fasciitis when you are examining the patient. Okay, so regarding the clinical presentation, I'm sure everybody knows how the patient present. They will present with sharp pain in the inferior aspect of the heel, and initially in the beginning, this pain is usually in the morning when the patient takes few first steps. So when the patient wakes up and starts to walk, and that is the time when the patient's pain is maximum. And after taking few steps, or after 1 or 2 minutes, gradually pain will subside, but it won't go away totally. They will have some kind of pain throughout the day. when they walk, but the pain is much more exacerbated or much more in morning hours. This is in early condition, but in later condition, if it is not treated, then they can have pain throughout their daily activities, especially when they walk. And on examination, we can see tenderness in palpation, and we can also see decreased dorsiflexion in the patient with plantar fasciitis, because they, by doing dorsiflexion, they tend to ease the tension in plantar fascia. So these patients tend to have decreased dorsiflexion when you examine the patient. And there is also one test which is known as Win-Lass test. The specificity and sensitivity of this test is very less, but this is the only test which is reported in text. Okay, so this in Win-Lass test, what we do is basically we extend the toes. So forceful extension of toes will it will cause pressure on the plantar fascia, and it can mimic the heel pain. So I also try this test in all the cases with plantar fasciitis. Here the sensitivity and specificity is only 50%, but this is the only test that is mentioned in the book. Okay, so here, if you see the ultrasound picture in the right side of the slide, you can see this white structure is a bone. This is the calcaneum. And as I've told you, this plantar fascia basically takes origin from the calcaneum, and it goes distally towards the head of the metatarsal. So as you can see in this picture here, the thickness of the plantar fascia is much more wider. So this is the typical example of the plantar fasciitis. Here, not only the thickness is more, so normal thickness of the plantar fascia is less than 4.5 millimeter. Okay, so normally 2.6 to 4 to 4.5 millimeter is the normal thickness of plantar fascia. And where to measure the length of plantar fascia? Just at the proximal site of insertion. So just at the where the plantar fascia takes its insertion or origin at the heel calcaneum, this is the place where you should measure, or where there is maximum dilatation. So where there is maximum enlargement, or at the site of at the beginning of the calcaneum, this is the area where you should measure. Okay, or where there is maximum thickness, this is the area where you should measure the thickness of the plantar fascia. And another thing you should be knowing is, sometimes the thickness of the plantar fascia can be normal, but still the patient can have a heel pain. In this condition, here the internal reflectivity of the plantar fascia plays an important role. It is said that internal reflectivity, or the disorganization of the plantar fascia, the fibers in the plantar fascia, is more important than actual measurement of the plantar fascia. I will be showing you the normal as well as the plantar fascia with a decreased internal reflectivity. So when the patient, if you are sure of the diagnosis of plantar fascia, but if you are measuring the thickness, if it's normal, then always see the reflectiveness of the plantar fascia. Here you can see the normal hyperechoic fibular pattern of the plantar fascia is lost, and this is black, and there is decreased reflectivity. So these two criteria are the most important criteria for the diagnosis of plantar fascia. Okay, so sometimes there can be bone spurs coming from the calcaneum into the plantar fascia. So this is also very much common, but bone spur itself doesn't cause plantar fasciitis. Okay, many a time people can come with the x-ray of the ankle, and they might show you the bone spur and say that I have heel pain because of the bone spur. So bone spur itself usually doesn't cause any more pain. So if it is associated with plantar fasciitis or plantar fasciopathy, or if the bone spur is too big, then usually it causes pain. Okay, so if you, this is the picture, this is how you will basically scan the plantar fascia. As you have noticed, patient is in prone position with the foot and ankle overhanging the edge of the bed. And if you see, the examiner is using high frequency linear probe. Okay, so and he has placed the probe along the long axis of the plantar fascia, and this is the image. In the left side is the normal image of the plantar fascia. You can see the calcaneum, and you can see a bridge like extension from the calcaneum. which basically separates the upper fat pad and the lower flexor muscle. So this basically forms the boundary between the plantar fascia, basically forms the boundary between the heel pad as well as the flexor digitorum brevis muscle. So if you see, there is a breeze-like or road-like extension which basically arises from the calcaneum and towards the digits. So this is the typical picture of the plantar fascia. So if you see the right side of the picture, here you can see the comparison between the normal plantar fascia as well as the plantar fascia with plantar fasciopathy. So here in the left side, you can see the thickness of the plantar fascia is very small. So it is less than 4.5 millimeter. But if you measure the right side of the plantar fascia, you can easily see there is a fusiform dilatation of the plantar fascia. So basically, I'm tracing the upper margin of the plantar fascia. Look, it is dilated in a fusiform manner. Okay, so here also there is a dilatation. So it is this at the site of maximum dilatation, you have to measure the thickness of the plantar fascia. In the lower part of the picture, you can easily see the normal thickness of the plantar fascia and the one with enlarged fusiform dilated plantar fascia. So if the thickness is more than 4.5 millimeter, then you can diagnose this as plantar fasciitis. Or if the thickness is normal, just see the internal reflectivity of the plantar fascia. If there is loss of internal reflectivity, or if the plantar fascia is more black. So if you see the left side of the picture, can you see there is not the upper left upper USG picture is a normal picture. Here is the normal fibrillar pattern is maintained. So this is the normal plantar fascia. But if you see the right side of the plantar fascia, here you can see more black structure is there. So there is decrease in internal reflectivity of the plantar fascia. So whenever you see you diagnose the patient of plantar fasciitis, always examine the opposite side of the plantar fascia as well. Okay, so and if the opposite side of plantar fascia is also normal, then do not ever forget to check the Baxter's nerve or Achilles tendon, because some fibers of the Achilles tendon will basically come behind the calcaneum and it is continuous along with the plantar fascia. Sometimes Achilles tendinopathy can also mimic plantar fasciitis, because sometimes the Achilles fiber are continuous with the plantar fascia fibers. So whenever you think a patient having plantar fasciitis, which is much more common, but if you see the ultrasound examination and if you think the thickness is also normal and the internal reflectivity is also normal, always check the opposite side and this heel and check the difference. And do not ever forget to scan the Baxter nerve as well as Achilles tendon, because these are also notorious for causing inferior heel pain. Okay. So another clinical condition that you should be aware is plantar fibroma. So plantar fibroma is similar to the hand. In hand, you have studied Jupiterian contracture, where there is nodular thickening in the palmar fascia and there is contraction of the digit. So similar to the hand, this plantar fibroma or plantar fibromatosis is also is a condition where there is a nodular thickening in various in places of the plantar fascia. This can be also a source of pain, and basically these nodules are of varying sizes, but it is always inside the plantar fascia. So this is the picture of the ultrasound picture of the plantar fibroma or fibromatosis. If you see the picture clearly, first see the lower part of the picture. Here you can see nice plantar fascia, but in the middle of the plantar fascia, there is a fibroma. Okay, there is an oval shaped or round shaped focal enlargement of the plantar fascia. But if you see proximally also the plantar fascia is normal, and distally also the plantar fascia is normal. But in the focal area where it is marked with yellow blue box, there you can see abnormal dilatation or oval shaped disorganization of the plantar fascia in the internal structure. So this is the typical picture of plantar fibroma or plantar fibromatosis. So it is also called as leather horse disease. Another name is leather horse disease. And in long axis, you'll be seeing this is the picture in the long axis. You'll be seeing elongated, typically oval shaped or round shaped, disorganized plantar fascia within the normal plantar fascia. Okay, so sometimes there can be one nodule, or sometimes there can be more than one nodule, and these nodules typically measures less than 2 centimeters. So this is another pathology that can cause foot pain, especially the inferior aspect of the foot pain. So this is the sagittal picture of the plantar fibromatosis, and the nodules are shown with this arrowhead, white arrowhead. You can see within the normal, there is a normal plantar fascia, and in various places of the normal plantar fascia, you can see nodular swelling. So these are the plantar fibromatosis or plantar fibroma within the substance of plantar fascia. So this is also a typical picture of plantar fibromatosis in a short axis view. Okay. Another pathological condition which is very much common in day-to-day clinical practice is heel pain secondary to nerve compression. So neural compression, especially the Baxter's nerve, or it is also called as inferior calcaneal nerve. If there is any problem in this inferior calcaneal nerve, then it can cause, or it can mimic pain similar to plantar fasciitis or fasciopathy. So basically, plantar fascia is supplied by inferior calcaneal nerve, and this inferior calcaneal nerve is a first branch of lateral plantar nerve. Okay, so if you see this picture, the posterior tibial nerve is this one, yellow in the posterior aspect of the tibia is the posterior tibial nerve. First branch of posterior tibial nerve is medial calcaneal nerve. Okay, after it gives medial calcaneal nerve, near the tarsal tunnel, it divides into medial plantar and lateral plantar nerve. Okay, so the first one is medial plantar nerve, followed by lateral plantar nerve, and the first branch of lateral plantar nerve is Baxter's nerve or inferior calcaneal nerve. So this nerve, once it arises from the lateral plantar nerve, it goes downward very much close to the calcaneum, and first it enters in between the muscle, that is adductor hallucis and quadratus plantae. So it first enters in this muscle plane, and then it turns acute 90-degree turn below the calcaneum between flexor digitorum brevis as well and abductor hallucis. So because of the sharp turn near the calcaneum, or because it has to travel within the muscle compartment, then this is the area where the nerve can get impinged and can cause Baxter's neuropathy or heel pain. So this Baxter nerve is a mixed nerve. So it has a sensory supply to the plantar fascia, but it also has a motor supply. It supplies to flexor digitorum brevis. It also supplies to the this quadratus plantae and adductor digiti minimi. So in case of long-standing Baxter neuropathy, you can have atrophy of digiti minimi as well as this quadratus plantae as well as this flexor digitorum brevis. So there can be, in case of chronic Baxter neuropathy, patient can have a flat foot because of the problem in the ligament as well as in muscles. Okay, so basically the compression of Baxter's neuropathy is mainly secondary to hypertrophy of the muscle, as it has to pass through the muscle compartment, and also near the calcaneum, because it has to take a sharp turn and go to the plantar fascia to supply it. So this is the picture of the Baxter's nerve and the normal course. So this is the posterior tibial nerve, and there is a lateral and medial plantar branch. So first branch of the lateral plantar nerve is Baxter's nerve. As you can see, it has to turn sharply and go to the inferior aspect of the foot. So this is the area where there can be impingement of the nerve. And so in the right side of the picture, here you can see the Baxter's nerve, which is shown by the white arrowhead. Okay, this is the white arrowhead where it shows the location of the Baxter's nerve. And as you can see, it is between the muscle plane, this abductor hallucis and quadratus plantae, and near to the calcaneum. So this is the site of compression of the Baxter's nerve. So in the ultrasound examination, if you see any signs of entrapment of this Baxter's nerve, you can go there under the guidance of ultrasound and give either dextroprolotherapy, or you can give local and steroid to dilate the compressed part. Okay, so this is the normal anatomical area where you can get a Baxter's nerve. And I think in the last class also, sir has shown you the site where we can get a Baxter's nerve in ankle ultrasound examination. He will be repeating in the next class also where to get this Baxter's neuropathy. So I advise all of you, when you are basically scanning plantar fascia, always make a habit to see the Baxter's nerve. Okay, so that you'll be having more practice in finding the Baxter's nerve, whether there is problem or not. And if there is normal plantar fascia, it is mandatory for you to go and check the Baxter's nerve under ultrasound. So normally, if the plantar fascia is normal, I've already told you, always scan the Baxter nerve. And main site of compression is between the muscle plane of adductor hallucis and quadratus plantar muscle, as well as in when it curves along the calcaneum. Sometimes there can be large spur in the calcaneum, which can compress the Baxter's nerve and cause Baxter's neuropathy. And in any other neuropathy, here also Tinel sign is positive. So if you just palpate or percuss the Baxter's nerve, area of the Baxter's nerve that is in the medial aspect of the foot, then you can have a pain in the inferior aspect, or the posterior aspect of the heel. And normally when Baxter's neuropathy is diagnosed, we basically treat the patient initially with conservative management. As you know, weight is also one of the main determining factor that can cause Baxter neuropathy or plantar fasciitis. So in conservative management, we'll tell the patient to decrease the weight. There are specially designed shoes which are available in the market. We can prescribe them these special shoes which can relieve Baxter's neuropathy or plantar fasciitis. Physiotherapy is also one of the most commonly done intervention or treatment. So initially we always go for conservative management, but if the conservative management is not helping the patient, then you can go ahead and go and inject steroid around the Baxter's nerve, or you can even do dry needling of the muscle, which is hypertrophy. But because muscle hypertrophy or muscle spasm can also cause compression to the Baxter's nerve and cause Baxter's neuropathy, we can also give PRP injection along the Baxter's nerve, or you can go for a cheaper alternative, that is inject 25 to 50% of dextrose at the site of compression of Baxter's nerve. Or if these things are not helping, you can go for shockwave therapy. If none of these things are helping the patient, then surgery is the last resort. Okay, so this is the treatment for Baxter's neuropathy. So another problem that is common is talonavicular ligament problem or navicular stress fracture. Especially this talonavicular ligament, as the name suggests, the ligament, it runs from talus to the navicular bone. So, and this is also one of the main ligament which basically reinforces the anterior capsule of the ankle. So this ligament can be injured especially in case of football players, because when you hit the football, this is the area where you basically use to hit the football. So this talonavicular enthesopathy or talonavicular ligament tear or sprain are much more common in rugby player or football players. And in ultrasound, you can see increase in thickness of this talonavicular ligament, especially when there is sprain, or there can also be loss of reflectivity, like in plantar fascia, in case of talonavicular ligament sprain. Okay, so if the talonavicular ligament sprain, another differential diagnosis can be stress fracture of the navicular bone. So as you can see in this ultrasound picture here, there is a diagrammatic picture also where you can see the ligament basically extends from navicular bone to the talus. So this ligament can get injured, especially in football player. So if it is pathological, the thickness of this ligament will be more, and will be loss of reflectivity of this ligament. And sometimes if you turn on the collar Doppler, you may see increase in vascularity within the area of the ligament. So this is the typical picture of the talonavicular ligament sprain, especially encountered in football players. So, okay, another ligament that can cause problem is bifurcate ligament injury. As the name suggests, it has the origin one in the bifurcate ligament. It is like Y-shaped. So origin is one, but it gets inserted in two different places. So it has a lateral portion as well as medial portion. So it gets origin from the calcaneus, but it is inserted the lateral portion is basically inserted in cuboid bone, and the medial portion is basically inserted in the navicular bone. So it is a Y-shaped structure starting from calcaneum, and one arm will end at cuboid, that is a lateral portion, and one arm will get inserted in the navicular bone, that is a medial portion. And tear or sprain in the of the bifurcate ligament is common during inversion injury of the ankle. So in inversion injury of ankle, the most commonly affected ligament is we have already discussed, that is talofibular ligament. This is anterior ATLF. So anterior talofibular ligament is the most commonly affected ligament. 70% cases, this ligament is getting injured, and remaining 20% calcaneo, this cuboidal ligament will be injured, and all other rest ligament are injured in a very small percentage. So one of the ligament that can be injured in the inversion injury of the ankle is bifurcate ligament injury. So here you can see the ligament, how you examine the bifurcate ligament. You can see he's examining the lateral aspect of the ankle, and he's using the linear high frequency linear probe, and the orientation is of the probe is similar to the sole of the foot. Here the probe is just parallel to the sole of the foot, and if you put one ultrasound one end at the calcaneum and another end at the cuboid, then you can see the calcaneo-cuboidal part of the this bifurcate ligament. And if you just rotate the probe, the distal part of the probe more towards the greater toe, then you will be able to see the calcaneo-navicular part of the bifurcate ligament. And as you can see in this picture, you can see there is anechoic septa within the substance of this calcaneo-cuboidal ligament. So there is basically a partial tear in the calcaneo-cuboidal part of the bifurcate ligament. Similarly, if you see the calcaneo-navicular ligament, here also you may find a sprain where there is increase in thickness of this ligament, or you can see partial or complete tear of this ligament. This is very less compared to injury to the ATLF. So another ligament injury that can occur in foot is Lisfranc ligament injury. So this Lisfranc ligament injury is one of the common in basically sports person, and it is the condition which can cause mid-foot pain in the athletic group of person. So this Lisfranc ligament, as you can see in this picture, it basically extends from cuneiform bone to the head of the base of the second metatarsal. So it travels obliquely. Okay, you can see this is the Lisfranc ligament, which basically extends from cuneiform bone to the base of the second metatarsal. So here also there can be injury, especially this injury when it occurs when some heavy object lands on our foot in the dorsal aspect of the midfoot. Then there can be injury of the Lisfranc ligament. Another is when the cars, basically if the wheel of the car rolls over our foot, then also it is one of the common cause of Lisfranc injury. Okay, so in the ultrasound picture you can see, so from the cuboid to the base of the metatarsal, you can see a beautiful ligament like a bridge extending from the cuneiform to the base of the metatarsal. So this is a normal Lisfranc ligament. But if you go downwards, you can see the normal architecture of Lisfranc ligament is lost. So this is a complete tear of Lisfranc ligament, which is common when we drop a heavy object in the midfoot or when our foot is run over by a car. So these are the normal condition where we can get Lisfranc injury. Here also, like in any other ligament, we basically go for, but if it's sprain, then we can go for conservative management. And if it's not healing, we can go for prolotherapy, either with dextrose or PRP. If it's a partial tear also, we can go for PRP or dextrose prolotherapy. But if it's a complete tear, then we have to ask our surgical friend to repair the tear. Okay, so another problem that is commonly associated with foot is superficial peroneal or fibular nerve entrapment. So we all know the superficial peroneal nerve supplies the dorsal aspect of the foot, except a small area, that is small first wave area, is supplied by the deep peroneal nerve. So whenever the patient with superficial peroneal nerve entrapment comes to your clinic, they will complain pain like neuropathic pain, burning sensation, or numbness in the dorsal aspect of the foot, or and it can extend to the lower part of the lower lateral part of the leg. So when the patient comes with neuropathic pain in the dorsal aspect, not the plantar aspect, then you always have to think the pathology that may be in the impingement of the superficial peroneal nerve. And basically the superficial peroneal nerve, it basically pierces the deep fascia between the peroneus longus and brevis in the distal 1/3 of the calf. So this is one of the area where it can get impinged. Or when it travels along the superficial fascia, then this is also one of the area where it can get impinged. Normally, the site of impingement, if you see, is usually about 10 to 12 centimeter above the ankle joint or proximal to the ankle joint. This is usually the site of impingement of superficial peroneal nerve. And in last class, we have already seen how to examine superficial peroneal nerve, and ultrasound guided injection of steroid or dextrose around the superficial peroneal nerve gives a very good excellent result in those patients suffering from the superficial peroneal neuropathy. Okay, so we can also go for, we can also go for cryoablation or radiofrequency ablation in these patients, because superficial peroneal nerve is basically a sensory nerve. So we can go directly for, if the steroid and dextrose prolotherapy is not helping, or if these intervention are giving very short duration of pain, you can always go for cryoablation of this nerve or radiofrequency ablation of the nerve. Or if these all of these modalities is not relieving the pain, then you can go for surgical decompression of this nerve. So another foot pathology is jogger's foot. So this jogger's foot basically means if there's any compression of the medial plantar nerve. So as I've told you, that posterior tibial nerve first divides, gives the medial calcaneal nerve, then it divides into medial plantar and lateral plantar. So the medial plantar nerve, it travels between the flexor digitorum brevis in the foot. So within the plane of flexor digitorum brevis, there is another two tendon which lies there, and these tendon are flexor digitorum longus and flexor hallucis longus. This flexor digitorum longus and flexor hallucis longus, within the two heads of flexor digitorum brevis, will intersect each other, and this is the site where there can be compression of the medial plantar nerve, and this intersection is also known as knot of Henry. So I'm sure in the coming class we'll be demonstrating you how to examine this intersection in the foot between the flexor digitorum longus and flexor hallucis longus. Here if you see the picture, between the plane of flexor digitorum brevis, there is a tendon, flexor digitorum longus and flexor hallucis longus. And here in this area, the flexor digitorum longus crosses over the flexor hallucis longus. And this area is also known as knot of Henry. So this is the area where the medial plantar nerve can get impinged. And if we get this pathology, patient usually complains pain and numbness in the plantar aspect of the foot. Okay, so here if you do, simply see the ultrasound, if the nerve is enlarged, then we can go for local anesthetic and steroid injection, or you can go for the if it is refractory, then you can go for a surgical decompression also for the jogger's foot. Okay, so another pathology that is common in foot is foreign body. Okay, so like in hand, foreign body, whether it's metal or metal sharpeners or glass or other wood particles, that can easily go into can find their way into the plantar aspect of the foot. And basically patient usually may recall the penetrating injury in the foot, and they may present with localized painful mass in the foot. So in ultrasound examination, all the foreign body are seen hyperechoic. So whether it's glass or metal or wood, it is seen as a hyperechoic structure. So this ultrasound image that I have I'm showing is a, here you can see a longitudinal hyperechoic structure. So this is the foreign body in the foot. So if it's wood, then normally there will be no acoustic shadowing, or there will be no reverberation. But if it was a glass or metal, then there can be posterior acoustic shadow beyond this foreign body, or there can be reverberation artifact beyond this foreign body. So this is typically the foreign body wood in the plantar aspect of the foot. And if you see nicely, there can be, you can see granuloma formation, the hypoechoic halo surrounding the foreign body. So this is basically a granuloma surrounding the foreign body. And sometimes if you turn on the color Doppler, you can also, you can see the increase in vascularity within the granuloma of the foreign body. So this is the typical ultrasound picture of foreign body. So here you have to remember, all foreign body will be seen as a hyperechoic fragment. Okay, so if it is glass or if it is metal, then there will be posterior acoustic shadowing beyond that foreign body, or there can be reverberation artifact beyond the foreign body if it's glass or metal. But if it's wood, then there will be no artifact, there will be no posterior acoustic shadow or the reverberation beyond the foreign body. Okay, so another thing, in the foot can be, there can be lots of incidents where there can be stress fractures in the foot, especially the small bones of the foot can undergo stress fractures. Okay, so for the diagnosis of stress fracture, normally the gold standard investigation or investigation of choice is MRI. But with use of ultrasound nowadays, we can also diagnose stress fracture with ultrasound also. So in ultrasound examination, we can see there is cortical. So in the picture, you can see there is a breakage in the cortical. So this is the normal cortical architecture of the bone, but suddenly you can see breakage of the cortical part of the bone. So this is one of the sign of stress fracture of the small bones of the foot. And there can also be like hematoma over the fracture, or there can be, we can see also see the periosteal elevation. So if you see nicely here, the two arrowhead in the upper arrowheads are basically showing the elevated periosteum just over the stress fracture. And if you turn on the color Doppler, you might well see the increase in vascularity at the site of stress fracture. So this is the typical ultrasound picture of stress fracture of the small bones of the foot. So actually, if I want to tell you about one of my clinical experience on diagnosing the stress fracture. One of my colleague came with fall injury with the extended hand, and he was complaining of pain in the wrist. And as we all know, when we basically land on the outreach hand and land on the hand, there can be a fracture of the scaphoid bone. And with the ultrasound itself, we could see the disruption of the cortical disruption, along with periosteal elevation and the vascularity in the hand also. So this modality may not be good for the management, but at the time of clinical presentation of the patient in the clinic, you can show the patient that you are having a stress fracture, and then you can go for further management. You can refer the patient to orthopedic department because fracture is one of the red flags. Okay, so once you diagnose, then you can refer the patient to the orthopedic colleague, because it is one fracture is one of the red flag. We are not basically treating the fracture. So for the diagnostic purpose only, this can be used, and it is very helpful. Without any radiological investigation itself, we can diagnose fracture and refer the patient to the our orthopedic counterpart for the management of the further management of the fracture. Okay, so uh, so another problem that can be associated with foot is plantar plate injury. I think we have already studied plantar plate in the hand. Okay, so plates are basically in the usually in the hand. It is usually between the between all the joints. Especially these plantar plates are more prominent in the hand metacarpophalangeal joint. Similarly, in the foot also, in between the metatarsophalangeal joint, plantar plates are located. These are basically ligaments, fibrous ligaments, from where the pulleys comes, and sagittal bands and pulley emerges and stabilize the flexor and extensor tendon of the hand as well as in the foot. So this is the typical ultrasound probe as well as position of the patient to examine the plantar plate. So as you can see, the examiner is using a high frequency hockey stick probe for examination of the plantar plate. So I usually use high frequency linear probe. I don't have hockey stick probe. With the frequency of 20 hertz, you can easily see. We don't need expensive gadget like hockey stick probe. We can see similar image with the high frequency probe, linear probe, but the frequency should be slightly more. It should be about 20 hertz is good to see all these structures. Okay, and so here you can see the probe is placed just over the metatarsophalangeal joint, first metatarsophalangeal joint. And this is the ultrasound image. You can see the flexor tendon over the plantar plate, and this is the metatarsophalangeal joint. And just over the metatarsophalangeal joint, you can see a grainy, uniform structure. So this is the homogeneous, grainy, uniform structure is a plantar plate, which arises just above the head of the metatarsal, and above the plantar plate is the flexor tender in a long axis view. So normally this plantar plate injury usually are common in female because of they wear high heel shoes, and wearing high heel shoes is one of the most common cause for this plantar plate injury. And another causes are hypermobility of this metatarsophalangeal joint, especially in gymnastic people, and in case of athletic people, this plantar plate injury is very much common. Okay, so among five various position of the plantar plate, second metatarsophalangeal joint is the most common area where plantar plate injury can occur. So if you see the ultrasound examination, this is the normal plantar plate where you can see grainy, homogeneous ecotexture of the plantar plate. But if you see the injury, so this is the picture where there is a normal plantar plate in the right side and plantar plate injury in the left side. So first let's see the right side of the picture, the normal picture. This is the metatarsophalangeal joint, and just over the metatarsophalangeal joint you can see the normal, grainy, homogeneous structure, that is plantar plate. But if you see the left side of the picture, you can see there is loss of this grainy, homogeneous structure just over the metatarsophalangeal joint. Instead, there is an anechoic black shadow over the metacarpophalangeal joint. So this is the ultrasound picture of injury of the plantar plate, which is most commonly occurring at second metatarsophalangeal joint. Okay, especially in case of female as well as in case of athletics, those who plays kung fu, gymnastic, judos. In these patients, this plantar plate insufficient is quite commonly seen. So another problem that can be associated with mid-foot pain is Friedberg's infraction. So in Friedberg's infraction is basically characterized by collapse of metatarsal head, mainly second or third metatarsal head, and this usually occurs when there is repetitive stress or trauma in the head of the second or third metatarsal space. As this is also very much common in athletics as well as in case of females because they are wearing high heel shoes. Okay, so wearing high heel shoes is are the most of the culprit for plantar fasciitis as well as this Friedberg's disease and other foot pathologies. Okay, and whenever there is repeated trauma in the head of second or third metatarsal, this will lead to microfractures, and this will eventually lead to avascular necrosis of the metatarsal head, and this can cause Friedberg's infraction. And if you see the ultrasound picture, you may be able to see irregularity in the head of, this is the metatarsal head and this is the phalanx. Okay, this is metatarsophalangeal joint, first metatarsophalangeal joint. So if you see nicely over the head of the metatarsal, you can see bony irregularity over the head of the metatarsal. So this is a typical picture of the initial phase or acute phase of Friedberg's infraction. And this Friedberg's infraction, always remember, it always involves second or third metatarsal head. Okay, so in X-ray also you can see the X-ray. In X-ray also you can see sclerosis in the initial part. In acute condition you can just see sclerosis, but in chronic condition or in old infracted condition, you can see even collapsed metatarsal head with irregularity on the head of the metatarsal. Here, basically, these conditions are managed by initially by offloading the heel. That means there are specially designed shoes which you can wear to decrease the pressure over this second and third metatarsal head. So, and we can also go for steroid or PRP injection in the initial part of the condition. Or if there is persistent pain, patient may have to go for decompression surgery by our orthopedic counterpart. Here also I want to focus. Always remember second and third head of the metatarsal. And in ultrasound picture, you can see like here there is irregularity or even collapse of this metatarsal head in a chronic condition. And you can also see synovial hypertrophy or signs of synovitis with fluid in the metatarsophalangeal joint. So in these conditions, you can inject steroid, basically steroid, or even PRP for the treatment of pain. So another common condition that is clinically encountered in our day-to-day clinical practice is Morton's neuroma. Okay, so Morton's neuroma, actually it is a misnomer. So there is it is not a true neuroma, but basically there is a perineuronal fibrosis or neural hypertrophy of the interdigital nerve as it passes between the two heads of the metatarsal. So it is not actually true neuroma. So, and it was first diagnosed by Thomas Morton in 1876, and it is most common in second and third interdigital space and third and fourth interdigital space. Here also, this is also much more common in female because they are wearing pencil tip like closed shoes. So one of the most common culprit for this Morton's neuroma is wearing a tightly fitting shoes or a closed foot, which is common in female. So the incidence, male is to female incidence is 5:1, mainly because of the footwear, the different footwear that the female people are wearing. So, and in these patients with Morton neuroma typically presents with neuropathic pain of the toes of the toes, and whichever interdigital nerve it is involving, the the neuropathic pain is at the site of that digit which it supplies, and normally the compression is in between second and third or third and fourth. Okay, so here also patient may complain of neuropathic pain, especially affected in the affected toes. There can be tingling, burning, and numbness in the affected toes, and patient can also say that he or she will feel like walking on a pebble when he wears the shoes. Or patient can also tell you that he is feeling sensation of the shoes or the socks being wrapped over the sole of the foot, or he is walking on the pebbles. So this is how the patient will present. And there is one test known as Mulder's maneuver. That means when you compress the foot laterally, then it will again cause irritation of this neuroma and can cause pain. And you can also sometimes see or hear palpable, audible click, which is known as Mulder's click, when you compress the foot laterally. So these are the tests to check Mulder's neuroma. Okay, so here also you can see the doctor is using high frequency hockey stick probe to check the Mulder's neuroma, and he's checking the Mulder's neuroma between third and fourth interdigit. So this is the second most common site of Mulder's neuroma. So if you want to, if these are the ultrasound picture of long axis and short axis. Upper one is of long axis and lower one is of short axis. If you see the upper picture, you can see a round or oval hypoechoic nodule in the plantar aspect of the foot, mainly in between the two metatarsal head. Okay, and usually the size of this neuroma or hypoechoic nodule is usually 1 centimeter or more. And but if you see carefully, you can see a nerve entering into this neuroma and exiting outside the neuroma. So here, as I've told you, this is not a true neuroma, but it is basically the neural hypertrophy or perineural fibrosis is main culprit, which will impinge the nerve and cause neuropathic type of pain wherever it supplies. Okay, and if you see the lower picture, this is the sagittal view or transverse view of the Mortis neuroma, and these hyperechoic structure are the head of the metatarsal, and so between these two head of the metatarsal, you can see a mushroom-like lesion. So there is some hypoechoic structure or nodule emerging between these two head of the metatarsal and coming out like a mushroom. So you can typically see mushroom lesioning in the plantar aspect of the foot, mainly in between the two heads of metatarsal. So this is also a typical picture of the Mortis neuroma. Here, this mushroom lesion can be more nicely seen if we compress the foot. If suppose this, if you imagine this is a foot, if we compress the foot laterally like this, then the mushroom lesion will be nicely seen. The mushroom lesion will be seen popping out between the two heads of the metatarsal. So this maneuver is known as Mulder's maneuver. And sometimes you can feel the click, or you can also palpate the clicking of the nerve as the nerve is displaced when we compress the lateral aspect of the foot. So this is called Mulder's click or Mulder's maneuver. So here also the treatment is basically, initially we have to choose appropriate footwear. We have to tell the patient to not to use closely fitting shoes or like closed shoes, and wear a shoes which has a wider anterior aspect, or there are specially designed shoes for these kind of people, but these are a bit expensive. Okay, so and another treatment is again local infiltration of local and steroid. We can also go and give alcohol injection for chemical neurolysis, or you can go for heat ablation, that is radio frequency ablation of this neuroma, or you can also go for cryoablation. If none of these things are working, we can go for surgical excision as a last resort for the treatment of neuroma. So before pain physician was there, all the motor neuroma were posted for surgical excision. But once the pain physicians are more and more in various part of the world, then surgical intervention for motor neuroma has decreased very much. So nowadays they are going for conservative management or minimally invasive treatment, that is injection of steroid or injection of alcohol around the neuroma, or we are also commonly using radio frequency ablation. And if cryoablation is available, and in Dardia, the cryoablation is available. So in Dardia, in Kolkata, we usually go for cryoablation for this Morton's neuroma. Okay. So, like in any other place, like in wrist or hand, ganglias and synovial cyst is also common in ankle and especially in the foot. Okay, so here also it is basically well-defined unilocular or multilocular structure can arise from the joint, capsule, or tendon. So these are the ganglia. So ganglia you can easily identify. It's a well-defined unilocular or multilocular structure with anechoic fluid inside the ganglia. And this the commonest site is at the talonavicular joint or at the level of sinus tarsi. And these ganglia are common in second to fourth decade of life. And if this ganglia itself is not painful, okay, we can you may have seen there are a lot with patient can have a large ganglia over the dorsal aspect of the hand or in the dorsal aspect of the foot, which is not painful. But if this ganglia is located in specific site, such as if it's located in tarsal tunnel, then it can cause pressure over on the posterior tibial nerve and can cause tarsal tunnel syndrome. And in these conditions, we have to take active intervention. Normally, the size of ganglia is about 1 to 3 centimeter, and it is seen as a well-defined anechoic or hypoechoic mass. So simply we can just we can aspirate this ganglia on ultrasound and inject a steroid. And if this is not helping, the last resort is surgical excision of the ganglia. Okay. Some tumors are also commonly seen in the foot, which can cause you problems, such as giant cell tumor, especially of tendencies are commonly encountered in pain clinic. So though we have to refer, once we identify the tumor, we are basically referring, but identifying and diagnosis is the main thing. Okay. So here patient can come with pain in the midfoot. Okay. And when we examine the patient, there can be a slowly growing lobular mass in the foot region, and this slowly growing mass usually arises from the peroneal tendon sheath or flexor tendon sheath, or they can arise from the digits itself. Right. So there can be homogeneous mixture of homogeneous and heterogeneous mixture which arises from the tendon sheath and can cause problem. So if you see the Doppler, the Doppler can so increase vascularity within the substance of this tumor. So once we suspect tumor, especially giant cell tumor, then usually we send the patient to do MRI for confirmative diagnosis, then FNAC and we usually have to, this is a red flag, we usually refer this patient to the orthopedic department. Okay, so hemangioma and vascular malformations are also common foot pathologies. Basically, these are characterized by increased cell turnover, especially the endothelial cells, mast cell, and fibroblast and macrophage, like in any other hemangioma or vascular malformation. And in ultrasound, we can see well-defined compressible solid echogenic or hypoechogenic mass or cystic serpingeous mass, basically with dilated vessels. And color Doppler, we usually use color Doppler to diagnose hemangioma and vascular structure. Here you can see the hemangioma with or without color Doppler. In the left side of the picture, you can see hemangioma, which cannot be nicely seen without the color Doppler. But if you see the right side of the picture, B, C, and D, you can easily see serpingeous or hypoechoic mass or cystic mass, which is taking up the color. So this is the vascular malformation or hemangioma of the foot, which can be a source of pain in the dorsum aspect of the foot. So this is also the red flag. Once we identify hemangioma and vascular malformation, we usually refer the patient, but diagnostics is the key feature. As we are using ultrasound, it is easier for us to diagnose and send the patient to the relevant department for further management. Okay, another problem that the patient can have in pain in the foot is peripheral nerve sheath tumor. So this peripheral nerve sheath tumor can arise from the large nerve, that is schwannomas. If this peripheral nerve tumor arises from the larger nerve, that is from Schwann cells, then it is called schwannomas. Or if it arises from the small cutaneous nerve, then it is called as neurofibromas. Okay, so peripheral nerve sheath tumor are either neurofibromas when it arises from the small cutaneous nerve, or it can be schwannomas when it arises from the large nerve. And in ultrasound examination, we can see hypoechoic fusiform dilatation with typical dural trail. Okay, so this dural tail is basically it represents the nerve which is entering or exiting this neuroma. Okay, so suppose there is a neuroma, a nerve is going inside the neuroma. So in this will be classically seen as hypoechoic fusiform dilatation with a rat-like tail or dural tail, either entering or exiting the neuroma. So, and nerve usually lies eccentrically in this neuromas, and normally we can see a surrounding basically rim of flat around the nerve also. And we can also sometimes see increase in vascularity if you are seeing using Doppler. And if the size of the mass is more than 5 centimeter, you always have to think of malignancy. So normally this peripheral nerve tumor is a benign lesion, but if the size is more than 5 centimeter, then it can be a malignant tumor. Okay, so this is a malignant soft tissue tumor. I have included the MRI T2 fat suppressed MRI as well as ultrasound picture of this malignant soft tissue tumor. And as I've told you, majority of foot and ankle tumor are benign, but sometimes we can encounter malignant tumor such as synovial sarcomas, malignant fibrous histiocytoma or Kaposi sarcoma. So these are all malignant tumor which we can sometimes encounter in our clinic. Okay, so here also if you see do the ultrasound evaluation, so there is one study done by Marzano et al. He had found that in 66% of the case, he has examined 35 cases of this synovial sarcoma, and he found out that in 66% of the case, the picture in ultrasound was focal nodular round or lobulated structure. Okay, and it was hypoechoic in 66% of the cases. In 14% of the cases, basically he found out that it was a complex mixture of both hypoechoic and hyperechoic soft tissue mass. And in 20% of cases, he found out that it was homogeneously hypoechoic mass. So the presentation can vary. So in ultrasound examination, it can either be solid or lobulated with a heterogeneous hypoechoic mass, or it can be also like only hypoechoic mass, homogeneously hypoechoic mass. So if you encounter such masses, then we usually refer the patient to the concerned department. But we have to know that synovial sarcomas are also commonly encountered in foot, and it is also most common type of malignant tumor in the foot. And usually these malignant synovial sarcomas are present between 15 to 40 years of life, and primarily it is extra-articular areas, and basically within the tendon sheath or bursa or interosseous membrane. In these areas, synovial sarcomas can be present, and it can cause painful foot. Okay, so osteoarthritis. Osteoarthritis in the foot is also very much common. Okay, so in ankle and foot also we can get a patient with painful ankle and foot, especially with osteoarthritis. As you can see in the picture, so this is the metatarsal and metacarpal joint. Okay, so between the metatarsal and this is the metatarsal joint. Here you can see the joint space is very much narrowed. Okay, so there is a loss of joint space. Along with loss of joint space, you can see irregular osteophytes arising from the margins of the joint space, which is a typical picture of the osteoarthritis. Okay, and you can also see synovial hypertrophy, and if you turn on the color Doppler, you can see increase in vascularity. So this is the typical picture of the osteoarthritis, and this is particularly common in midfoot, especially in tarso-metatarsal joint or in midfoot. So you can get effusion, synovitis, as well as decrease in the joint space, and along with decrease in joint space, you can see irregular osteophytes arising from the margin of the joint. So this is the ultrasound picture of the osteoarthritis of the tarso-metatarsal joint. Okay, so bursitis is also common in the foot. Mainly the adventitial bursa is much common, and this adventitial bursa usually develop in area where there is high pressure. Okay, especially it mainly appears just over the head of the metatarsal, above the flexor tendon and subcutaneous tissue, mainly because of the high pressure exposed to the mainly over the head of the metatarsal. So here also you can see the main location is just this is the head of the metatarsal, and this is the flexor hallucis longus tendon. And because of the because this area of the foot is exposed to maximum or high pressure, here there are chance of appearance of bursitis. So this is called adventitial bursitis, and it is located between the subcutaneous tissue and flexor tendon of the foot. So in these conditions, if you see here also, you can see the black anechoic fluid in the bursa and features of synovitis. In these conditions, you can simply inject local and steroid in this area, which will take care of the pain of the patient. And another common feature in foot pain is gout. As we all know, gout usually, or it is but a patient with gouty arthritis or elevated uric acid usually have pain in first metatarsophalangeal joint. In 50% of cases, the first metatarsophalangeal joint is involved, but the gout can happen in any other joint also, especially the distal part of the joint. And in ultrasound, there is two key features that you have to know. One is double contour sign, which is also seen in X-ray. It is also known as urate icing, and then another is snowstorm appearance of the synovial joint. So here, like in any other joint, here synovitis can be seen with fluid in the joint, or there can be or synovial thickness can be seen. We can see periarticular erosion, but characteristically you will see double contour sign and snowstorm appearance in the patient with gouty arthritis. So double contour sign is basically due to the deposition of the monosodium urate over the hyaline cartilage. As you all know, the hyaline cartilage is black in color. Fibrocartilage is like hyperechoic in color. So in the joint, which is in the joint where it is covered with hyaline cartilage, that is black. Hyaline cartilage is usually black in color. Just in the outer surface of the hyaline cartilage, due to the deposition of this monosodium urate, you will be seeing a double contour sign, or it is also known as urate icing. Similarly, you will be able to see snowstorm appearance inside the joint. So what happens is, because of the crystals of the monosodium urate inside the joint, it will cast a acoustic shadow. And these urate crystals are seen as a hyperechoic foci within the joint self. So these hyperechoic foci within the joint along with synovitis and synovial membrane thickening, it is seen as a snowstorm appearance. And these are the characteristic feature of the gout in the gouty arthritis. So here you can see this is the upper picture. If you see carefully where my marker is located, that is just the, if you see arrowhead, you can see a white line over the hyaline cartilage. So this is the urate icing or double counter sign. One hyperechoic margin is the cortex of the bone. Another hyperechoic margin is basically deposition of the urate or monosodium urate over the hyaline cartilage. So this sign is known as urate icing or double counter sign. This is also seen in X-ray also. If you check the X-ray of the patient, knee X-ray of the patient, if it is due to the gouty arthritis, you'll be seeing a double counter sign in the X-ray. And this, the whole arrow is basically a synovitis. You can see fluid in the synovium, and you can also see the thickening of the synovium. So this is not a double counter sign. Okay, double counter sign is this small area. If you are if you see nicely, this is the articular surface. Articular surface usually has a hyaline cartilage covering it, and over the hyaline cartilage, which is anechoic, you can see a line. So this is a double counter sign or urate icing. And the black area, this is effusion. Okay, and this is the synovial thickness. And if you just turn on the color Doppler, you can see basically lightening of the color Doppler. And the picture below is basically a typical picture of the snowstorm appearance of the gout. So this is the first metatarsophalangeal joint, and you can see the capsule is distended. Okay, the capsule is distended, and if you see nicely, you can see this is the articular hyaline articular cartilage. Over the hyaline cartilage, you can see a line. This is known as urate icing or double counter sign. And just above it, you can see multiple white hyperechoic structure. So these are the crystals, monosodium urate crystal within the synovium. And these crystals looks like a snowstorm appearance. And this is also known as snowstorm appearance sign in case of gouty arthritis. And cellulitis is also common. We can also diagnose cellulitis or at least confirm cellulitis with ultrasound in the foot. So normally when there is subcutaneous edema, it can be due to fluid overload, or it can be vascular insufficiency, or it can be just edema secondary to trauma or infection. Okay, so and there is usually characteristic thickening and indurated skin of the subcutaneous tissue. But and these findings are usually non-specific. But if you see if you put an ultrasound probe where there is subcutaneous edema, and if there is increased vascularity, so this is the sign of basically cellulitis or any infection. If you don't see any, if you just see increase in subcutaneous tissue edema, it can be due to the fluid overload also, or vascular insufficiency, or just acute trauma, acute inflammation following trauma. But if you see there is increased vascularity and thickening of the tissue with the ultrasound probe, then it is usually the signs of cellulitis. And usually the systemic signs of cellulitis has also to be matched, like fever. Patient is usually having fever, there is usually pain, redness will be there. So systemic and local examination will also help you in diagnosis. But with ultrasound also you can confirm diagnosis of cellulitis by just putting the probe where there is swelling or redness or edema. If you see thickness, increase in thickness of the soft tissue, especially soft tissue, and if you turn on the color Doppler, if there is lightening of the color Doppler, then it can be a sign of cellulitis of the foot. So here also you can see here the normal architecture, subcutaneous architecture is lost. If you see, this is the normal architecture of subcutaneous fat. But if you see the architecture of this yellow circle line here, completely the architecture is lost. There is a mixture of hypoechoic and hyperechoic shadow, and there can also be posterior acoustic enhancement of the shadows. So this is the picture of cellulitis. But I want to stress, this is not commonly seen and not commonly practiced also. I have just included this image just to differentiate that cellulitis can also be used, ultrasound can also be used to diagnose cellulitis, but this is not the confirmed diagnosis. We always have to check with systemic other features like fever, blood test, and other inspection. You will be seeing redness and swelling in that area. Will be usually complaining of throbbing type of pain. So these clinical aspects should be correlated, and you can also use ultrasound just to see whether it's due to the swelling is due to the overload or due to the infection. So this is another picture of the abscess in the foot, ultrasound picture. Here you can see a simple fluid collection can appear as a focal anechoic region. So here you can see a focal anechoic region like cystic structure can be seen, and this can be edema. Okay, so what is the difference between this anechoic structure and ganglia? In ganglia, basically, if you turn on the color Doppler, that lightening of the color Doppler will not be there. Yes, there can be a cystic fluid within the well organized like space. Cystic fluid and echoic fluid can be there, but in ganglia there is no hypervascularity if you turn on the color Doppler. But in the abscess you can see fluid, and this fluid is surrounded by the hypervascular like tissues. So this is the typical picture of the abscess in the foot or anywhere else in the body. So here another thing you have to know, that in the abscess usually there can be internal separation can be present, but there should not be any internal vascularity. Okay, if there is too much of internal vascularity there, then the diagnosis might go to the hemangiomas or vascular malformation. So typically present patient with abscess usually have focal anechoic region with normally posterior acoustic enhancement like any other fluid. So if there is any fluid, if the ultrasound beam goes through that fluid, then there can be posterior acoustic enhancement normally, whether it's abscess or fluid. But the interesting part of the abscess is when you turn on the color Doppler, the margin of the anechoic fluid will light up and take the color Doppler. So this is one of the classical picture of the abscess in the foot. Okay, so so this is the most of the pathologies that we may encounter in foot. So if there is any question, I'm ready to answer. But without anatomical correlation, you may be finding a bit difficult to correlate with these pathologies. But in next class, sir will be showing you the anatomy part very nicely. Thank you. So any questions, my friend, students, regarding
Sir,
Sir, can you tell us something about flat foot syndrome?
flat foot syndrome? So basically what happens is the arch of the foot is maintained by various ligament and muscle. Okay, so especially as I've already told you, one of the most important the ligament that maintains the arch of foot is the plantar fascia, and this arch of foot is also maintained by the peroneus longus muscle. Okay, if you see the peroneus longus muscle, from the lateral aspect of the lateral malleolus, it curves, and then it again goes back below the foot, and it gets articulated with the cuneiform bone. So if there is any pathology in peroneus longus tendon, or in case of there is any pathology in chronic pathology in plantar fascia, then the arch of the foot can slowly be less. So this is basically our flat foot syndrome. Flat foot syndrome is not particularly one disease, but it is a constellation of the condition. Sometimes more dominant part will be peroneus longus tendinopathy, that can also call a flat foot condition, or that can be associated with plantar fasciitis or other ligament that maintains the arch of the foot, like short plantar ligament and the long plantar ligament, or it can be congenital also. Sometimes patient can be born with flat foot.
So what are the approaches to manage those kind of patient when they have prolonged pain only with that flat foot?
So unfortunately, basically, if there is only a flat foam, if the condition is secondary to plantar fasciitis or peroneal tendinitis, we can initially address those problems, and we can also take help of various. There are in the market. There are various sources like orthodontics, like sources are there. We can use those sources, or special sole are available where there is preformed arches are available. We can use that, but depending upon the pathology, we have to manage. Suppose if it is congenital, then we may not be able to do much. So you can just tell the orthopedic people or refer to the orthopedic people, and we can use specially designed footwear for those people. But if flat foot is secondary to peroneus longus tendinitis, we can manage peroneus longus tendinitis by using like conservative management with like long-term duloxetine or physiotherapy, or we can use PRP injection to correct it. Or if it's secondary to plantar fasciitis problem, then you can manage plantar fasciitis and simultaneously use various type of shoes to manage such condition. So it depends upon the cause and management. If it's congenital, we may not be able to do anything other than referring to orthopedic physician, orthopedic doctors, and use of specially designed footwear. Or if it is depending upon the condition, if it's peroneus longus problem, we can treat the peroneus longus problem. Or if it's plantar fasciitis, we can treat the problem of plantar fasciitis for the treatment of flat foot syndrome. Okay.
Thank you, sir.
Okay. Any
Sir,
other?
Sir, in plantar fasciitis, what is the exact point of injecting the steroid or
So wherever you have to scan, and wherever there is decrease in reflectiveness of the plantar fascia, that is the area to inject. So normally it is usually the problem is at the central bundle of the plantar fascia. So as I've told you, there are three bundles: central, lateral, and medial bundle. Normally the central bundle, which arises from the calcaneum, central calcaneal tubercle, and at that area you can see fusiform dilatation. And where there is fusiform dilatation, that is the area where you have to inject PRP. If you are going inside the plantar fascia, go with PRP. If you are injecting steroid, you should inject above and below the plantar fascia, not inside the plantar fascia. So if you are injecting steroid, always go above the maximum dilated, fusiform dilated part, and below the plantar fascia, not inside. But if you are using PRP, you have liberty to go inside the tendon and do multiple puncturing of the tendon where there is maximum dilatation or fusiform dilatation, and inject the PRP where there is like where you suspect injury to the ligaments. Okay, so if you are using steroid above and below the fusiform dilatation of the plantar fascia, if you are using PRP, see with the ultrasound image wherever there is more fusiform dilatation with associated anechoic or loss of reflectivity of the plantar fascia, that is the site. That means at the site of attachment with the calcaneum. So I'll show you in the picture. Okay, so this is the plantar fascia. So this is the area of the pathology. I have to come from here in plane or do multiple puncturing, and this is the area. If you are giving PRP, this is the area to inject PRP. Okay, here if you see distally, this is the normal ecotexture of the ligament. So here you can see loss of ecotexture of the ligament. So this is the area at the site of attachment to the calcaneum. This is the site for injection of the PRP. Or if you are giving steroid, above the plantar fascia and below the plantar fascia, this is the site of injection of the steroid, not inside the plantar fascia.
Okay, sir. Thank you.
Okay. Okay.
Sir, what is one question? Sir, like what should be the first line, like steroid injection or PRP for plantar fasciitis or any other treatment options, sir?
So I usually go with conservative management. I usually go for stretching of the Achilles tendon and the calf muscle, and I always go for conservative management. Okay, so there are, especially if you see the YouTube, or if you always refer the patient to the physiotherapist. Okay, and try conservative management first. Don't go for initially injection. So there are beautiful exercises which can take care of plantar fasciitis or fasciopathy if it's initial. So I usually see what is the duration of the problem. So if the duration of problem is 4 to 6 months, then I usually go with the conservative management with the stretching of Achilles tendon and rolling your foot over the ice, okay, or doing massage and also duloxetine. I usually prefer duloxetine, oral duloxetine, because duloxetine is the drug which can decrease the pain threshold or increase the pain threshold, so that patient will not feel pain and they can do the physiotherapy nicely. If duloxetine is causing problem, or even with physiotherapy patient is not relieving, then I will tell the patient, I'll advise the patient to go for the injectable treatment. And there are two injectable treatment. One is steroid and another is PRP. I usually say the advantage and disadvantage of both. So with steroid, the advantage is pain relief is immediate. Okay. But
Yes, sir.
but the problem, but the treatment is temporary. Okay, so it is not the natural healing process. We are just taking care of inflammation and decreasing pain. So if the patient want immediate pain relief, then I would go and inject a steroid. But I would always focus on PRP, because PRP is the one which will take care for a long-term pain relief. There is regeneration of the ligament that is injured. Okay, but the problem with PRP is it takes time. Okay, usually pain relief with PRP is usually it takes about 2 to 3 weeks time. So I ask the patient, what is your requirement? Okay, immediate pain treatment, or which has a very less benefit, or you want a long-term pain relief. And I usually do negative counseling of steroid and do positive counseling of PRP. And depending upon patient choice, I'll go for
आंटी लोग
injection.
बाहर गया है, हमको क्या पता क्या करते
But
हैं।
always go for conservative management. But before
खा के भी
going
आता
to
है ना
the,
कितना बार, हमको कैसे पता
please
रहेगा।
mute. Okay, who is talking? Please mute.
Sorry, sorry.
Okay, so depending upon patient condition, but always go for conservative management followed by the injectable management. And PRP, the advantage is long-term pain relief, natural pain relief. So there is no other side effect. Okay, but the disadvantage is onset of pain relief. It takes about 2 to 3 weeks time. You always have to counsel the patient, because what patient thinks is once you inject, pain should be gone. So in Nepal as well as in India and other in places also, patient thinks that injectable treatment, once you inject, pain should be over within 5 to 10 minutes. Okay, that is only possible with steroid. With PARP, pain will persist. Gradually, pain reduction will be taking place, and it can take weeks. 2 to 3 weeks is minimum for pain relief with PRP. So depending upon patient choice, we go for intervention. Understood?
PRP, yes, sir. Sir, PRP like just matlab should we should repeat the session, or like just one single PRP is sufficient?
So what I usually do is, because injecting in plantar area is very painful. Okay, I think you may have done, some of my colleague or student must be using injection in the foot. Okay, so it is very painful. So before injecting any drug, whether it's steroid or PRP, I usually block the posterior tibial nerve. Okay, so it is very important. Okay, listen. So always go, if you are injecting anything in the sole of the foot, always block the posterior tibial nerve first, then go for injection to the plantar fascia. So if you are doing if you are injecting PRP, first do multiple tenotomy, puncture the fascia with multiple times. So you are creating injury, which will cause neovascularization, and there will be healing. And then inject PRP within the substance of the plantar fascia where there is problem. Could I
So
answer?
can we give
Yes.
PRP with
Yes.
visco as well in this plantar fasciitis also?
Just it is a very small area, ma'am. Just 2 ml of plantar fascia is plantar. This is much because in knee usually we go for this all viscose because the area we can inject it volume is more. Okay, plantar fascia. Remember the thickness. It is just 4.5 millimeter. So there is I don't think there is much more use of visco. Only PRP is good enough, ma'am.
Sir, I want to know PRP, like, sir, just one session or should we do
Okay,
second?
okay. So
And what is
what
the volume of PRP?
I usually go not more than 3 ml. But inside the tendon, I usually go 1 ml, 1 to 1.5 ml. But if you are injecting above and below the tendon, also like 1 ml above the tendon, 1 ml below the tendon, and within the tendon, 1 to 1.5 ml is more than enough. We cannot inject more than 1.5 ml inside the tendon. And
Yes.
regarding repetition of the procedure, I usually call the patient after a month because pain reduction is usually seen, typically seen, slow reduction is of pain can be seen after 2 to 3 weeks. So after 1 month of treatment, I usually call for follow-up and see the pain reduction. If 50% pain reduction is there, I usually tell the patient to wait another 1 month. If there is less than 50% of pain reduction, then then only I go for second session. So depending upon the improvement of the pain of the patient, you have to plan the session. Okay, normally
Yes, sir.
2 session is more than enough. Rarely 3 session is required. 2 sessions is more than enough. So but it depends upon the response of the patient of the first session. And you
Yes, sir.
usually call the patient after 1 month or 1.5 months, because at that time only the benefit of PRP or pain
Yes,
reduction
sir.
can be appreciated.
Yes, sir.
Okay, so there is no
Yes.
defined session, 2 or 3 sessions. Usually call the patient 1 or 1.5 month after the injection, see what is the or ask for the evaluate the pain reduction. Okay, if it is more than 50%, I usually don't do second injection. Call the patient again after a month and evaluate. If the pain reduction is very nice, is going gradually, there is more and more pain reduction, then 1 session is good enough. But in follow-up, if there is less than 50% of the pain relief after the first injection, then only I go for the second session of PRP in the plantar
Yes.
fascia. But I want to focus here to all. After the injection, pain relief is not immediate. It takes at least 3 weeks to 1 month for after the injection with the pain relief. So you have to counsel the patient beforehand, because
Yes,
if
sir.
I'm patient or if you are patient, you'll be expecting pain relief immediately after the injection or within 5 or 6 days after the injection, which is not true in case of a PRP injection in plantar fascia. Okay?
Yes, sir. Yes, sir. So one more,
Please tell.
sir, like, I want to know, sir, can you show how to block this posterior tibial nerve? Where?
Okay, posterior tibial nerve in you have already seen tarsal tunnel. Okay, Tom, Dick, and bloody nervous Harry. Okay, you just put the probe in the tarsal tunnel. Hello, can you get me?
Yes, yes, sir. Yes, sir.
Okay, so you put the probe in the tarsal tunnel. That is one footprint. One end of the footprint is at the medial malleolus, and another is over the calcaneum. And in this, you can easily see the tarsal tunnel with tibialis posterior. Okay, flexor digitorum, and between the flexor digitorum and flexor hallucis, you can see the 3 vessels, one artery, and it is also known as Mickey Mouse sign. Okay, so one artery will be there and two like vein will be like Mickey Mouse ear will be there. Just behind that or below that, you will be seeing honeycomb appearance of the posterior tibial nerve. So you just put the needle in the in plane manner and give about 2 to 3 ml of lignocaine. That will block the posterior tibial nerve. And after the blocking posterior tibial nerve, you can proceed for injection for plantar fasciitis or any other injection in the foot, because
Yes,
it is
sir.
very painful.
Yes, sir.
Okay, always block posterior tibial nerve, especially if you are doing intervention of PRP or steroid in plantar fascia.
Yes, sir. So is there a possibility of any live demonstration of this nerve block? today?
Yes,
No.
not today because I am at home and sir will be
Okay.
taking this class. Again, he'll be repeating anatomy in next class, and I will
Okay,
definitely
sir.
convey your message to sir that you want
Sure,
to
sure.
see you want to see the posterior
Sure,
tibial
sure.
bone.
Sure,
It is
sure,
very
sure, sir.
important. Okay.
Sure, sure. Thank you so much.
Okay. If I was in clinic, I could have shown you, but right now
Sure.
I'm in my study room, so I
Oh,
will not be able
okay. Okay, sir. I didn't know that.
to. Okay.
Okay. Thank you, sir.
Okay. Any other question, my friends, colleagues? Any other question? And another my tip to you, all of you, okay, practice always because plantar fasciitis is so much common that every one day or another day or even in 1 week you will get a plantar fasciitis patient. So whenever you get a patient of plantar fascia, always make a habit to go and see the Baxter's nerve. Okay, so always see the Baxter's nerve and practice how to locate Baxter's nerve while you are examining the plantar fascia, because sometimes patient can come typically with pain with like that of plantar fascia, but plantar fascia can be normal. Both the thickness can be normal, reflectivity of can be normal, and in those conditions you have to go to Baxter's nerve and scan it. So I'll also convey to sir in next class in coming week to show you how to scan Baxter's nerve. And I request all of you, whenever you have chance to scan the plantar fascia, always scan the Baxter's nerve, just to make yourself adapted to see the Baxter's nerve.
Sir, there is one general query.
Please tell me.
Sir, will you be showing musculoskeletal scanning of lumbar region of the back?
When musculoskeletal scanning of the back has already been taken care, no, in previous class.
Sir,
No, sir.
Of the spine, sir.
Of the spine.
Yes, sir.
We haven't had a class of this MSK spine.
Sir, it
Sir,
is not
sir, query.
schedule.
In the schedule is not there, sir. In the schedule,
Yes,
the lumbar is not
not there.
included.
So there is a good so spine ultrasound is one of the most favorite topic of Dr. Gautam Das sir, respected Dr. Gautam Das sir. I'm sure. So you are enrolled in musculoskeletal ultrasound. It cannot be that without a scan of lumbar spine, he will not let you go. So even if it, so even if it is not there in schedule, I think sir will definitely show you the scan of the spine. Don't worry.
Okay, sir.
Okay, that is one of the favorite chapter of Dr. Gautam Das. So even if there is if it's not in the schedule, we can request him to show you the scanning. Do not worry.
Please, sir, we need one class over that, sir.
Okay.
So one more query.
Sir,
I have missed many Kahoot session. I don't know how it counts.
So it is only there for 2.5 days only. So we cannot again provide you the count. It will be there for only 2.5 days, I think. So I'm extremely sorry. I will not be able to provide.
It will be added for the internal assessment or something.
In the final test, you have all the tests are again based on count, I think. But daily after the class, it will expire within 2.5 days. So we'll not be able to again repeat the count.
Yes, sir. But will it be counted in the internal assessment or something?
No.
Okay. Right. Thank you, sir.
It is only for your practice and your confidence.
Yes, sir.
Just for your self assessment, not for our assessment. It will be done in final.
Okay, sir. Sir, as I told you, I have given one shoulder injection. Would you like to give antibiotics after the intra-articular injection?
No. If I basically if the patient is diabetic and if the fasting and if you suspect that there can be, because all the injection are given in all aseptic precaution you have to take, whether it's a diabetic patient or any other patient, while doing injection, you have to take all aseptic precaution. So normally antibiotic is not preferred. But if you are injecting in a diabetic patient where the fasting or postprandial blood sugar is in borderline, then I would recommend a short course of oral cefixime or oral antibiotics, but not rampantly to all the patient. Especially if you suspect there can be infection. Normally, when the infection can be in the diabetic patient, there can be we are injecting steroid, and the patient is diabetic. Patient is taking oral hypoglycemic drug or insulin, but even though that, if you suspect the blood sugar is not tightly controlled, then that is the only condition where I or in general practice we give antibiotics, but not to all the patient.
So generally, what we do, we use the normal jelly for ultrasonography.
I use lignocaine jelly, the one which we use for catheterization. I
Okay,
use
and
that jelly.
okay, sir, is there a possibility that we get those sterile jellies, which is usually shown in the videos or something? Is it available in India?
So I have no idea. In Nepal, it's not available. So unfortunately, I have to use the lignocaine jelly. I'm sure you all have seen lignocaine jelly. So that is
Yes,
one
sir.
of the trick. You can use lignocaine jelly. That is mostly sterile. Okay, cheap and sterile.
Okay,
And
right.
that's lignocaine jelly it will not cause any damage to your probe. You should never use alcohol, spirit, betadine, chlorhexidine on the footprint of the this one ultrasound probe. You can use normal saline, okay,
Okay.
okay, and other jellies. Okay, what I use is cheap and best is I use lignocaine jelly. It is cheap and best. It is sterile also. It is
Yes.
easily available also. So, and I basically, that is my trick. I use lignocaine jelly.
Okay, right. Thank you, sir.
No, you no need to go to market and give
Fine.
and do excessive expensive. Just use lignocaine jelly, sterile lignocaine jelly.
Yes, sir. Thank you, sir.
Welcome.
Sir, in the same link, I'm asking a question. Sir,
Uh-huh.
do we need any camera cover or something like that
Yes,
just to maintain the sterility?
yes. Always, if you are thinking, always we get in market we can get a with a probe cover we can get, depending upon the size of the probe, we can get a preformed probe cover also, or we can use tegaderm plastic, or even you can use condoms. Like if cheap and best is also, condoms are also cheap and best. Okay, you can use that also.
So what are you all practicing, like in date practical, like which is cheap also and available also?
I use tegadrum plastics
Just for
and
the probe size
probe size.
or
I
this?
while doing intervention, I use
Yes, sir.
tegadrum, or I also use the condoms, which are also cheap and best.
Yes, sir.
Uh,
Yes, sir. Yes,
or
sir.
because it is sterile, it is cheap, and it is readily available. I use that also. I use also tegadrum plastic, which is also cheap and best. But I don't use the fancy, like expensive other probe covers. Okay, that is
Yes, sir.
also available in market. It depends upon what is the clinical setting. If you can use that, but if you use these things, but there is no excuse of not using any of the. You have to use either three. Okay, you have to use aseptic precaution depending upon your clinical availability, like tegadrum plastic, or even condoms can be used. Or if you can use, or if it's available, if the patient is willing to pay, then whole plastic preformed covers are also available. But you have to use any of these three. You cannot you do the procedure without any aseptic precautions.
Yes, sir. But as a beginner, what I have seen is if we use, of course we have to use them. It
Uh,
hampers the visibility, it lowers the visibility,
no, no,
clarity of
no,
the.
no. Just another for you, okay, for everybody. One of the trick is use a glove. Use a glove, the
Okay.
sterile glove.
Yes, sir.
What you can do is, what I usually do is, I take one sterile glove, okay, and if you remember, in the glove there is one rim is there, rubber rim is there.
Yes,
I
sir.
usually tear that, okay, and I fold the glove, and in the folded portion I put a lignocaine jelly and put that probe, and then use the the rubber margin of the glove to fix it. So that is one of the
Okay.
cheap and best. I'll demonstrate, okay? In next class, I'll demonstrate how to use glove, the normal surgical glove, as a probe cover, which is sterile, cheap, and best. And I'll demonstrate. Right now, I'm in home, okay? I don't have any
Yes, sir.
in the plastic, this one. But in next class, I promise you to show you
Yes, sir.
all how to use a sterile glove as a probe
Yes,
cover.
sir.
It is cheap and best. And I think you all will love it.
Yes, sir.
I'll
Yes, sir.
show
Thank you
you,
so much.
okay?
Yes,
Next
sir.
class,
Sure,
that
sure.
is my responsibility. I'll show you. And in my residency days, I learned this from my teacher was S.N. Bawa. He was retired brigadier general in I studied in Manipal Pokhara, my residency in
Yes, sir.
anesthesia, and there he taught me how to use the plastic glove for the probe cover. I still use it. That is old and
Yes, sir.
gold technique, cheap old and
Okay,
gold
sir.
technique. I'll show you, everybody.
Yes, sir.
Okay.
Sure, sure.
Okay. Any other questions? Okay. Any other question, my friends? I'll stop the recording. Okay. Stop the recording. Okay. Any other question, or shall we say goodbye for today? Hello.
Thank you, sir.
Okay. Okay. See you next week. Okay. Have a great weekend. Bye.
Good night, sir.
Bye.
Ah.
Yes,
Thank
sir.
you,
Good
sir.
night, sir.